So we're here to talk to you about Pathway and the Pathway Partnership Programme, which has been running for the last couple of years with a generous grant from the Health Foundation. So I'll let Paul introduce himself first.
Sure. My name's Paul Hamlin. I'm a project manager for Pathway, and I've been working on what's previously known as our social franchising project, but we are now kind of semi-rebranding it as the Pathway Partnership Programme.
And my name is Chris Sargent. I'm a GP. I had a GP surgery for homeless people in Brighton called Arch, and also GP lead for our local Pathway team in the hospital. And I also work part-time for Pathway on this rollout of new Pathway partnership teams. So just a little bit of background about Pathway first of all. So Pathway is an independent charity that started in 2010 with the aim of improving the care of people in the inclusion health groups. And the definition of inclusion health varies a little bit depending on who you ask, but we take it as meaning people who are experiencing homelessness, people who are vulnerable asylum seekers, gypsies and travellers and sex workers. And we've, as I say, we've had this programme over the last couple of years to increase the number of Pathway teams in hospital. We're currently on 11 with, in fact, 2 just about to launch now and 1 at business case stage. And we have teams sort of geographically across England, 1 in Ireland and 1 in Australia, which was started after the people there came to our annual conference and decided to take this intervention to the other side of the world with great success. So why are we interested in these groups? So these are the groups with the worst health outcomes in our society, focusing on homeless people. There's premature mortality, so commonly see figures of people in their 40s dying as an average for people who are street homeless. There's a 10 times mortality rate for any given age in this group. So people in the inclusion health groups for any given age will be 10 times more likely to die than somebody not in the inclusion health groups. There's been a recent piece of work which has sort of finally nailed what we'd always suspected, which is that the frailty of people in their 50s who are, it was a hostel population that they studied, is about equivalent to the frailty you'd expect to see in regular population in their 80s. So this is the explanation for why people who've been in inclusion health groups during their lives need services sooner, need care sooner, need to be in nursing homes sooner than the general population. But of course, the services aren't set up for people of these ages. There are higher rates of all illnesses in the inclusion health group. So you may expect the complications of alcohol dependence to be higher in the homeless population. You might expect mental health problems to be higher, complications of substance misuse to be higher, but it's all conditions that are higher. So certain conditions, say hepatitis C is about 50 times higher in the homeless population than the regular population, but even sort of ordinary illnesses like COPD will be 15 to 20 times higher. Hypertension is higher, skin parts, everything is higher in these populations. There's also a high rate of trimorbidity, probably around the 30 to 40% mark, by which we mean a concurrent chronic physical health problem, chronic mental health problem, and a dependency issue. So that's sort of taking the dual diagnosis idea one step further. So all of those conditions obviously interact with each other and make each other worse, and it's very high in our populations. So what do Pathway teams do? The aim of a Pathway team is to be an in-reach team, which works in an acute trust, which is GP-led and multidisciplinary, to identify, support and help plan the discharge for all the homeless people who are in the hospital, with the aim of stopping repeated admissions for that person, which are obviously bad for that person, bad for their health, bad for the staff who are dealing with them, bad for staff who are having to discharge people out to nothing. They find that very distressing, and bad for the hospital itself in terms of the management and the finance of the hospital. To have the same person repeatedly coming in with the same issue is financially very bad too. So it's a situation which everybody can benefit from. So the idea is that the team is in the hospital 9 to 5, Monday to Friday. It's easy to refer to the team. So we have a very simple referral system that anybody in the hospital can say, we've got a person on the ward that we think is homeless, could you please come and see them? And then we take it from there. The main interventions are to make sure the person's comfortable, make sure they've got what they need while they're in the hospital, make sure they understand what their care is, what's actually happening with their treatment. Often people have no idea what's happening with their treatment or when their discharge is planned. We do things like get people newspapers and sweets and cheap mobile phones so they can stay in contact with people on the outside, tell people where they are. Get them clothes so they can be discharged from the hospital with a bit of dignity. But the main thing that we do is actually plan the discharge so that the person, when they go out, goes out to a better support service, range of support services than they came in with. So we try and ensure that they have a GP, that their substance issues are being dealt with, that they have follow-up from mental health services if they need it, that they have a benefits claim running, and they have some sort of social support to go out to, and they know where the services are in the community. We also lead a multidisciplinary team meeting, which starts off as once a week to try and bring the community and the acute services together. We talked in some of the other groups about the division that there can be between community services and acute services, and our patients tend to fall down those cracks, and they need the services to come around together around the person to make sure there's a sort of safety net to stop them falling between. We know that this reduces the number of people who are discharged to sleeping rough. The studies that have been done show it reduces from about 15% to about 4%. We know that it improves the connection with and use of community services and reduces the acute service use. We know that it improves people's quality of life, and we know that their housing status is improved once they leave the hospital, having been seen by a pathway team. As a sideline, we also do quite a lot of education of staff and students. So the team in Brighton, there's a medical school attached, and we teach all the fourth year medical students in groups of about 20 about planning the discharge of homeless people from the hospital and why it's important for that to be done in a way which is different from people who've got somewhere home to go to. We've got fairly high level buy-in to this approach as well. So we're in the NHS long-term plan on page 42 as an example of good practice, and we're also in the NHSE list of evidence-based interventions that reduce health inequalities. So there's badge of approval there as well. And Paul, I think look in the next slide.
Thanks, Chris. Yeah. So I'm just going to briefly talk you through how you can get the ball rolling to start a pathway team in your local hospital. So you might be a hospital trust, commissioner, or a passionate local advocate, and there's different things you can do to work with us to start this off. This has been a big area of focus of Pathways work over the last 10 years. But the adoption of our service model has been quite slow. We've had 10 teams in 10 years. So we're now trying to speed that up. We're trialing a funded support package for commissioners who want to start a team. And this was originally supported by the Health Foundation as part of their Exploring Social Franchising program. But as I mentioned at the beginning, we are renaming it the Partnership Program because that probably describes what it is a bit more closely. And also we found some people were put off by that term, franchising. So we've been asking local champions to talk to us and just trying to spread the word about the model. So this starts by supporting the local champion or a commissioner to carry out a needs assessment and make a business case for setting up a new team. The needs assessment involves talking to hospital and community staff about what's being done locally currently around homelessness and starting to work out where things might be improved. We've also got a methodology for determining the numbers of homeless patients attending a hospital, and this gives us a bit of a guide to the size of pathway team that might be needed. And lastly, if commissioners do want to set up a team, we're now offering a support package that includes face-to-face and telephone support, staff training, and also an online manual with guidance, quality frameworks, and practical tools. New teams also join the network of existing pathway teams for sharing of ideas and mutual support. And there's a web link here if you want to find out a little bit more. That's it. Any questions?